Hello, everyone. Well, first of all, I would like to thank each one of you for being here today. I know some of you, the journey has not been easy, but that's the reason why we're here for you. You have this patient organization who have all the information needed for you, and please don't hesitate to look at NCAN website so that way you can also learn all the informations and also webinars that NCAN has put together for you all. It is my pleasure to be with you all today.
Let me see if I can keep this thing from falling down. Here you go.
It is a pleasure for me to be with you all today, and I also want to thank all my colleagues who also dedicated their time to come here and talk about their expertise in neuroendocrine tumors in different areas in medicine. And please don't hesitate to also speak with them during the break as well. We're here for you. I know that a lot of you has been difficult having this diagnosis and the expectations of what needs to follow, but with that, I want to let you know that we're working hard. We are really dedicated to develop better therapies for neuroendocrine tumors at the same time to be able to improve quality of life. And that's what we're doing here at the NIH where I work. We do research. Dr. Blakely also do research as well at the NIH, and you're going to hear from him from the surgical perspective. And with that, I want to welcome everyone. And again, please don't hesitate to speak to each one of us during the break and ask any questions. This time, we're here for you. So please do not hesitate to ask any questions anytime. Now, what I'm going to discuss now is the medical management of neuroendocrine tumors. So these are, the incidence of neuroendocrine tumors has increased exponentially over the last decades. Just to explain to you this graph. So we have this graph, which is all other cancers like prostate cancer, colon cancer, and we can see that this has been stable. But as you can see, the incidence of neuroendocrine tumors has increased over the years and over the decades. Moreover, we can see here that the neuroendocrine tumors by site has also increased in incidence, and we can see that we have an increase in incidence of rectal cancer, rectal neuroendocrine tumors, GI neuroendocrine tumors, pancreas neuroendocrine tumors, and we also have seen an increase on all on different neuroendocrine tumors by site. And you may ask yourself why we're seeing more neuroendocrine tumors. One of the reasons is because we have better diagnostic tools like we used to have like 10 or 20 years ago. Now with the gallium dotatate scans, I'm sure you're very familiar about that diagnostic scan. Moreover, there may be changes in the genes over time. That's what we call epigenetics, and that's something that we wanted to understand as well. Neuroendocrine tumors can be anywhere in the body. And as we can see here, there is different organs that can be affected and form neuroendocrine tumors, because neuroendocrine tumors arise from the neuroendocrine cells that can be anywhere in the body. As we can see, we have a neuroendocrine tumor of the thyroid, neuroendocrine tumor of the lungs, pancreas, adrenal, small intestine, colon, rectum, appendix. Most commonly, is the pancreas and the small intestine, and that's something that we're going to focus on my talk today. I'm going to also discuss briefly about the lung neuroendocrine tumors, especially the ones that produces hormones, and we're going to discuss more about that. Most neuroendocrine tumors of the pancreas are non-functional, and when that means non-functional, it doesn't produce a hormone that can cause symptoms. But in terms of the small bowel neuroendocrine tumors, up to 90% of patients may develop symptoms, especially when there is in the liver, and we're going to discuss more about that. In terms of grading and classification of neuroendocrine tumors, and that I think is something that we need to learn. I'm not going to discuss about neuroendocrine carcinoma. Dr. Aman Shahan will discuss more about how do we diagnose neuroendocrine carcinoma. So I'm going to focus on the well-differentiated neuroendocrine tumors. well-differentiated neuroendocrine tumors, how do we know it's well-differentiated? And that's also based on the Ki-67. And you may ask, what is the Ki-67? The Ki-67 is a proliferation index. It tells me how the cells are able to divide under the microscope. And as you can see, the well-differentiated grade 1, the Ki-67 is less than 3. Well-differentiated neuroendocrine tumor grade 2, the Ki-67 is between 3 and 20. Now there is a new, the WHO in 2019 and 2020 described a new category in the well-differentiated neuroendocrine tumors where the Ki-67 is greater than 20, but usually less than 55 in terms of the numbers, and that's a grade 3 well-differentiated neuroendocrine tumors. And the reason why I'm mentioning this is because it's important to differentiate between grade 3 NAT or NET versus grade 3 NAC or NEC, and that's why I'm not going to touch base about this because Dr. Shahan will discuss more in detail, and like again, we're going to only focus in my talk about the well-differentiated neuroendocrine tumors. Moreover, up to 90% of neuroendocrine tumors may express somatostatin receptors in the surface of the cell, and because of that, dotted scan is a good scan for diagnosis and as well staging, and also tells me which patients may benefit from treatment, and we're going to discuss also about that. If you have any questions about the grading, please let me know. I had a question earlier from one of our patients today, and it was wanted to understand between grading and staging, which is two different things, and I understand that can be a little bit confusing. Grading is what I discussed, grade 1 to grade 3, and thus we have the well-differentiated neuroendocrine tumors, which is different from the grade 3 neuroendocrine carcinoma. But also staging is where the tumors are in the body, whereas stage 1, which is only localized in one area, stage 2 may involve some lymph nodes, and stage 4 is when the tumors are elsewhere in the body, outside of the original tumor where it was located. As tumors start to differentiate, because the Ki-67 tells me how the cells are able to divide on the microscope, but that number also tells me how it's going to progress, the tumors are going to progress versus slow versus more rapidly. And when the tumors start to progress more rapidly, sometimes they lose the receptors in the surface of the cell, the somatostatin receptors, and they're more avid on the glucose scan, on what we call the FDG PET scan. And Dr. Shahan also will discuss more in detail, because that's part of our therapeutic for neuroendocrine tumors. In terms of the clinical presentation of neuroendocrine tumors, I mentioned earlier, most of neuroendocrine tumors are non-functionals, meaning that they don't have specific symptoms. And those non-specific symptoms can be anywhere from abdominal pain, it can be also weight loss, it can also be some obstructions, intestinal obstruction as well. Some of these neuroendocrine tumors, small bowel neuroendocrine tumors, produces serotonin, and we're going to discuss, and that can also cause fibrosis around the tumor. I'm sure Dr. Blakely will discuss more in detail. They can have other non-specific symptoms like nausea, bleeding. But because these non-specific symptoms, our patients that with neuroendocrine tumors may be going multiple times to the physicians without not having a diagnosis. And also because of that, a lot of the time we have delayed diagnosis, and sometimes when we diagnose a patient with neuroendocrine tumors are more on the advanced stage, and the tumors are localized in the liver. A lot of the, often patients with neuroendocrine tumors are misdiagnosed with irritable bowel syndrome. So I think that's a very important area as well for primary providers as well to understand about neuroendocrine tumors, so that way we can diagnose our patients earlier. But like Marianne mentioned earlier, for 7 years prior her initial diagnosis of neuroendocrine tumor, she was having all the symptoms and she didn't have any specific diagnosis, and that's why advocate for yourself, like she mentioned earlier, is very important, because we still need to work more in educating our patients in neuroendocrine tumors, and our physicians as well, to make the early diagnosis. I know this is a busy slide, but I'm just going to go in terms of what this means. So neuroendocrine tumors are heterogeneous. And when I say that, it's not like one size fits all in terms of treatments. The treatment of neuroendocrine tumors is personalized from patient to patient. What I may recommend one patient may not be necessarily for another patient, and that's very important because I know that sometimes between patients they speak and they say, well, I recommended this and somebody else recommended something different, but it's something that I want you to keep in mind, that the treatment of neuroendocrine tumors is personalized. And also that also requires an expert team, not only from medical oncologists, but also from surgeon, interventional radiologists, nuclear medicine. So it is a multidisciplinary team that needs to be informed and give the approach in terms of what is the best treatment options for patients with neuroendocrine tumors. And one of the reasons is because neuroendocrine tumors presents different from patient to patient. Some patients may have very low tumor in their body when we look at the scans. Some other patients may have more of a larger tumor when we look at the scans. Some of them can be every different parts in the body, and some others can only be in the liver. Some others may be stable, and they may be stable for years, and we don't necessarily need to take any action in those situations, but some others, they grow, and that's when we need to make the decision what would be the best treatment options. Also the location, which part of the intestinal tract are located as well. And we discuss about the differentiation, whether it's well differentiated or poorly differentiated. Again, I just want to make sure that we are discussing today about the well differentiated neuroendocrine tumors. And it's important to know whether the tumor is producing hormone or not, because if the tumor is producing hormones and you have the symptoms related to the hormone excess, then we need to discuss different approaches for that. And also very important about the somatostatin receptors, whether they are positive on this gallium dotatate skin, whether it's 68 gallium or 64 copper dotatate skin. I think that's important as well to know in any patient with well-differentiated neuroendocrine tumors, because the scans help me to stage, meaning where the tumors are, but at the same time it tells me whether the patient may benefit or not from Lutathera, and we'll discuss more about that. So this is the treatment landscape of neuroendocrine tumors, and when I see this, it gives me hope, because before the 2000s, you can see there was not that many treatment options for neuroendocrine tumors. But now in the last 2 decades, you can see that there is now many different approaches and treatments for neuroendocrine tumors. And that's the reason why when I see this, it gives me hope, because not just that, but we're also working to develop better therapies for neuroendocrine tumors. 20 years ago, we didn't have that many options, and now we have a lot more options. The only issue is about sequencing. And again, and that's the reason why is the treatment is very personalized from patient to patient, because sometimes we don't know what will be our first line of treatment, or second line of treatment, or third line of treatment. That's kind of like one of the questions that we have, even with the net experts. Sometimes we don't know what is the best sequencing, and we're going to discuss more about that. Now, whenever I discuss neuroendocrine tumors with the fellows, one of the things that I discuss is like, is a tumor functional? Meaning if the tumor is producing hormones. And then the second question I ask is like, okay, we know patients have neuroendocrine tumors, we know where the tumors are located in the body, and the second question I ask is, besides the functional, what do we need to do for the symptoms related to the hormone excess, or what we need to do in order to control the growth of the tumor? And that's very important as well, because a lot of the treatments that we have can help for both. And that's why we need to kind of like determine as well in terms of our sequencing of treatments. Like I say earlier, we don't have a specific sequencing, but that's some of the discussions that we have our patients as well. What are the risks and benefits for each therapy? But I always discuss, even with my fellows, what do we need to do in a patient that have a functional neuroendocrine tumors? What do we need to do to control the symptoms? And we have different options that we can provide to control the symptoms. And what do we need to do to control the tumor growth? And we're going to discuss more about that. So now let's discuss about the GI neuroendocrine tumors. As I discussed earlier, more than 90% of patients with Carcinoid Syndrome, the reason why is because the small bowel neuroendocrine tumors produces serotonin, and the way we measure serotonin is with the urine 5-HIAA. I'm sure some of you are very familiar with this test. A lot of the time when the patient has this Carcinoid Syndrome is because it's involved in the liver, and with primary tumors in the distal, small intestine, or proximal colon. I'm sure Dr. Blakely will discuss a little bit more about that as well in terms of the GI neuroendocrine tumors and when to do the surgical approaches as well. So now let's discuss about Carcinoid Syndrome. What is what is carcinoid syndrome? So it's a series of signs and symptoms. Most commonly, we see patients that had diarrhea. I think flushing and diarrhea are the most common symptoms in a patient that had carcinoid syndrome related to a small intestine neuroendocrine tumors. And patients that also have carcinoid syndrome, they may also have heart valve abnormalities, and the reason why is because this excess of serotonin can also accumulate in the heart valves, and because of that, that can cause scar tissue, and that can also cause dysfunction of the heart valve. Some of these patients with neuroendocrine tumors, they sometimes need a heart valve replacement, so that's why it's important that every patient that is diagnosed with a small bowel neuroendocrine tumor with excess of serotonin, we need to make sure that you see a cardiologist every 1 to 2 years to make sure that we prevent what we call carcinoid heart disease, and if it happens, we can detect earlier to be able to make recommendations. There is other non-specific symptoms as well related to the neuroendocrine tumors, like shortness of breath, and also as well we discussed about the flushing. And I think you're familiar with the 5 E's because there are certain situations that can exacerbate the symptoms related to the carcinoid syndrome, such as eating, emotions, alcohol, exercise, and also having any type of local anesthesia as well, so, during the dental procedure. That said, I know that we are familiar with these 5 E's, but that doesn't happen to everyone. Like, for example, if a patient say, well, I want to have like a glass of wine, you know, you will experience how you feel about the flushing, and then you know. If this is really something very uncomfortable now, you know, but I really don't try to, you know, prevent some of the things that we usually enjoy in day-to-day. And, but just to be aware that there are certain foods, certain situations that may exacerbate, but that's usually more the flushing more than any other symptoms. So we discussed that a small bowel in neuroendocrine tumors produces serotonin. This excess of serotonin can cause carcinoid syndrome. And that's why it's very important that we control the excess of serotonin. It's important because serotonin is the main driver for the carcinoid syndrome. So it's important that when we need to target to lower the serotonin excess, it's important because the serotonin also has been demonstrated on having some tumor growth as well. It's important that we understand about not only the excess serotonin, but also the effect of serotonin, because it can also play a role in developing of carcinoid heart disease, as we discussed. It can also cause about mesenteric fibrosis. Dr. Blakely may touch base on the mesenteric fibrosis, as well as because it can also affect the heart valve, can also cause increased what we call pulmonary hypertension. And control of serotonin exposure is important to improve quality of life as well as prognosis in patients with carcinoid syndrome. And how do we do that? So one of them is the injections, the monthly injections, the somatostatin agonist, either lanreotide or octreotide. One of the questions that my patients ask is like, there is one better than the other. We really don't have comparison, head-to-head comparison. Lanreotide is easier to administer compared to the octreotide. At the end of the day, it's a patient choice of what they would like to have in terms of the monthly injections. Sometimes, if the symptoms are not, some of the symptoms can be quite profound, and sometimes the recommendations are, instead of giving it every 4 weeks, maybe giving it every 3 weeks, and that sometimes can help with the symptoms as well. But there are other things that we can use also to control the excess of symptoms related to carcinoid syndrome, and one of them is telotrestat. So what is telotrestat? And that's the brand name for that is called Stramelo. Telotrestat, what it does, it blocks the enzyme that converts to serotonin. This is what we call that the rate-limited enzyme of tryptophan to serotonin. And when they did the studies, just to let you know, when they did the studies, not only we saw a decrease on the level of serotonin, so these are the negative numbers, and we saw a decrease on the level of serotonin, but also on the patients that were taking telotrestat, it also we found as well that there is decreased the number of bowel movements per day, and that's kind of one of the symptoms that is, as we discussed earlier, flushing and diarrhea is the symptoms that our patients usually it can be quite devastating, and some of these episodes of diarrhea can be 10 times per day, and entelotristat has been proven to decrease the number of bowel movements per day. It can also lower the serotonin. I think what we're trying to understand about this medication is what other effects may have. Currently, the medication is only approved for carcinoid syndrome diarrhea. So if you have diarrhea that is not controlled with somatostatin agonist, then this will be a medication that we recommend as the next line of therapy. Dr. Shahan will discuss about clinical trials, but I think it's worth mentioning about this medication called paltusotine. Oops, sorry. This is an oral somatostatin agonist. Dr. Shahan is open at the University of Kentucky at MD Anderson, and Dr. Shahan, who will discuss about clinical trials later today, I'm sure she's going to discuss about this. But this is an oral form of somatostatin agonist, and they're including patients that have symptoms related to carcinoid syndrome and carcinoid syndrome diarrhea. This is an ongoing study, I think, in patients that would like to have an improvement on the symptoms related to the carcinoid syndrome. I will definitely reach out to Dr. Shahan since he has the study open. Now, let's discuss about pancreas neuroendocrine tumors. Approximately 10 to 30% of pancreas neuroendocrine tumors secrete hormones, and because of that, that results in different clinical syndromes. And that's what I may discuss a little bit of that. I may not necessarily go in details on each one of this, but I'm here all day and I'm happy to discuss any other or answer any questions related to hormone excess related to pancreas neuroendocrine tumors. Majority of pancreas neuroendocrine tumors do not, like I say, do not produce hormones, but most commonly, this is from the small bowel, but we see pancreas neuroendocrine tumors that can produce insulin. So insulin, whenever we eat, the pancreas secrete insulin to lower the glucose. So you have a lot of insulin, is going to really lower your glucose and develop the symptoms related to hypoglycemia. It can also cause another pancreas neuroendocrine tumors that is also found in the duodenum, as well as the gastrinomas. The excess of gastrin stimulates the acid in the stomach, and because of that, patients may develop ulcers. They can even bleeding in certain situations as well. Diarrhea is associated with pancreas neuroendocrine tumors producing gastrin. We have also the VIPoma. These are more rare. These VIPoma, glucagonoma, and somatostatin producing neuroendocrine tumors are much rarer, and we're going to discuss a little bit about that. And again, if we have anyone in the audience that has any of these, please reach out to me and during the break, and we can discuss further. I'm just going to discuss a little bit about thoracic neuroendocrine tumors, because thoracic neuroendocrine tumors, or lung or thymic neuroendocrine tumors, they can also produce excess of hormones, and we will discuss more about that. And again, with these functional neuroendocrine tumors, two things that we need to discuss with our patients: what do I need to do to control the symptoms related to hormone excess? And the second one, what do I need to do to control the growth of the tumors? Now, insulinoma. So as discussed earlier, what is insulin? Whenever we eat, the glucose levels goes up, and then insulin then is secreted by one of the cells in the pancreas to lower the glucose levels, because we cannot live with having high glucose levels all the time, because that can also cause complications as well. And that's what we call patients with diabetes. That's when patients have very high levels of glucose, and sometimes that can also cause other complications. In normal conditions, when we have this elevation of glucose after we eat, then the insulin is secreted to lower the glucose levels. But what happens is that sometimes these pancreas neuroendocrine tumors may produce excess of insulin, and that excess of insulin can certainly cause a lot of symptoms and cause the hypoglycemia. Usually we recognize a patient that has insulinoma is a patient that has very low glucose levels, less than 50. That's what we see. That also have related symptoms related to the low glucose level of hypoglycemia, and it could be any of those symptoms that we discuss here: feeling anxious, hungry, fast heartbeat, dizziness, fatigue, headache, feeling irritable, and then that is resolved as well with a high contact sugar. So we call trial just by having these symptoms. This is a very rare type of pancreas neuroendocrine tumors. Usually the insulinomas are diagnosed quite earlier. But we do have a few patients that, despite being resected, sometimes they can go to other places as well. And whenever it's in other places, it still produces insulin. That's why we need to discuss what we need to do in order to control the symptoms related to the low glucose levels. And what are the symptoms? Surgery is an important choice, and Dr. Malucci will discuss more about surgical resection of pancreas neuroendocrine tumors in a patient that is, as I discussed, the danger about having an insulinoma is because it can lower the glucose levels to very dangerous levels. Because of that, we need to make sure that our patients that has an insulinoma can have frequent meals that is rich on carbohydrates. Sometimes continuous oral glucose may be needed. Sometimes they need to have an IV line where we can give glucose as well. There are certain medications that can help to reduce the levels of insulin. And of course, very important, the somatostatin agonist. I always tell my patients, somatostatin agonist has two functions, either lanreotide or octreotide, can help control the symptoms related to hormone excess, but it also helps to slow down the growth of tumors, and we're going to discuss more about that. The other one that we see is gastrinoma. So gastrinoma, meaning that we have a neuroendocrine tumor that produces excess of gastrin. So these patients may have different symptoms such as diarrhea, they can have peptic ulcers, something can cause bleeding and perforation. Some of the patients are diagnosed in those stages as well with the gastric neuroendocrine tumors. Very importantly, we have a patient that have a gastrinoma. Important that patients are taking this, what we call the proton pump inhibitors, to lower the gastric effect or the gastric excess and the symptoms related to that, and that's why we give these medications, usually a higher dose than what we do in normal person that just requires this type of medication. So they require a high dose twice a day of this medication. And again, this is something that every patient that have excess of hormones, whether it's a small bowel or pancreas neuroendocrine tumors, we need to discuss what other options we can do to help, and those are including surgery, liver ablation, embolization. We have Dr. Kassin later today who is going to discuss more about the indications of what we call liver-directed therapies, and as well other systemic therapies. This is a busy slide, and I'm not going to go in with this. I know that you're going to have access to these slides too, but these are very uncommon pancreas neuroendocrine tumors. We discuss here the symptoms and the general measurements, and again, I'm happy to discuss during the break more about this. Now let's talk a little bit about the lung neuroendocrine tumors, either the what we call bronchial or as well thymic neuroendocrine tumors. This is a question that I sometimes get from our patients, that they can also produce excess of hormone. One of the hormones that patients with lung neuroendocrine tumors can produce an excess to is the serotonin. It can also cause carcinoid syndrome. But also there is another hormone, this is less common, but it still can happen, and it's important that we recognize, is that sometimes these lung neuroendocrine tumors may produce a hormone. This is called the ACTH, and the name is adrenocorticotropic hormone. I don't need you to remember that name. The only thing that I need you to remember is that this hormone stimulates excess of cortisol. So cortisol is a hormone that is responsible for the fight and flight response, and is produced by the adrenal gland, which are very tiny glands on top of the kidney. And I always tell my patients, if we cut the adrenal gland in half, we have two layers, and the outer layer is one of the hormones that produces the cortisol. So if we have this tumor that is producing this excess of hormone, then we'll stimulate excess of cortisol in the adrenal gland, and that's what we call, it can cause the symptoms called Cushing's syndrome. And the Cushing's syndrome is also a series of signs and symptoms that we can see here. It can also cause low blood glucose. They can have the moon faces. There is a little fat pad in the back of the neck. It can also cause high blood pressure, purple striate, weaken the bones as well, and break the bones in certain situations. So in this situation, it's important that we block that excess of cortisol, and there are medications for that. But sometimes in order to remove the stimulus, sometimes in certain situations, we need to remove the excess, the stimulus of producing excess of cortisol. Again, this is very rare, but I still need to mention, because sometimes these symptoms or this clinical manifestation becomes unaware for a lot of us, even providers. Now let's discuss about systemic therapies. I think in terms of the management of neuroendocrine tumors, we discussed about the somatostatin agonists. Those are the monthly injection or the short-acting sandostatin. We also, there's 2 of them, octreotide long-acting or lanreotide. We also have your peptide receptor radionuclide therapy, and we discuss what that means, and that's with Lutathera, 177 lutetium dotatate. Lutathera is the brand name. We also have other therapies like sunitinib or everolimus, and these drugs, what they do, they block the blood vessel supplies going into the tumor, and we're going to discuss about that, and when to give chemotherapy, because chemotherapy may not be necessarily for everyone, and we're going to discuss more about that. So this is, and I know there's a lot of busy slides, but I just wanted to take you over what this means. So we discussed that the injection, somatostatin agonist, either lanreotide or sandostatin, the function is that it can control the tumor growth, but it can also control the hormone productions in neuroendocrine tumors. Now, as I say, up to 80 or 90% of neuroendocrine tumors may express the somatostatin receptors in the surface of the cells, and even if we have a positive skin, then it's also worthwhile as well to give this type of treatments as well. And I don't want to, whenever, I like to explain this to my patients, because I always tell my patients, knowledge is power. That's one thing, but at the same time, I want you to understand where the data comes from, because I'm giving you something that may have some side effects, but I also need to explain to you why. And I think it's a good question for you to ask to anyone, why I'm getting this treatment versus this other treatment. And it's important that we understand and get ask that question to any provider, and I think that's always something that I like to teach our patients as well. But where it came from is that there is a benefit on this is progression-free survival, meaning they stabilize the tumors. These medications initially, when the studies were done, they found that by giving this monthly injection, stabilized the tumor more than if you were not given these injections. And that's what we see here on this graph. So that's what we call the Kaplan-Meier curves, and that's what we see the benefits, the y-axis, as we can see here, the characteristics of what we see in here based on the time and days. And we can see that the patients that received the monthly injections did better compared to the ones that did not receive the monthly injection. And that's why, based on that information, it was approved by the FDA for the management. Sandostatin initially was for the management of hormone-related excess symptoms, but then lanreotide as well was subsequently approved to not only to control the symptoms related to hormone excess, but at the same time because we learn as well that it stabilizes the growth of the tumor. Doesn't necessarily shrink, and that's important because some of our patients is like, if I take it, it's going to shrink the tumors. It doesn't necessarily shrink the tumors, but it stabilizes the tumor for long periods of time. So we have the injections, we can be every 28 days, and that's what we discussed, but also in patients that have these flushings, there is also the breakthrough shots, and that's short-acting octreotide, and that can also be given in certain situations. Then that's mainly to control the symptoms. The short-acting is only to control the symptoms. Now, everolimus. When to give everolimus? So everolimus, what is everolimus? It treats cancer by stopping cancer cells from reproducing and by decreasing the blood supply into the cancer cells. Initially, when the studies were done, the physicians who did the study, they found that it has some activity not only in pancreas neuroendocrine tumors, but also in GI and as well as lung neuroendocrine tumors. And what they found is by giving this drug, it can also stabilize the tumors. Doesn't necessarily shrink the tumors. There were some patients that they saw a little bit decrease in size of the tumor, but it's mainly stabilize the tumor. Now, the reason why I'm saying this is because there is an indication for the small bowel neuroendocrine tumors, and I'm going to discuss at the end when do we give that. There is the other one, is called the sunitinib. Sunitinib is part of the family, we call this the tyrosine kinase inhibitors. Similarly, tyrosine kinase is a type of drug that blocks the blood vessel supplies going into the tumor. And then also when they did the studies, that's mainly for pancreas, not for small bowel, for pancreas neuroendocrine tumors. They saw that also stabilized the growth of the tumor as well. I'm telling you these options, and we'll discuss my approach on what what I give in certain recommendations, because as I say, there is no sequence of therapies for neuroendocrine tumors, but I'll discuss when and how I give that. So now this is the dot-to-day scan. So in the past, before the dot-to-day scan was approved in the United States, we used to use the octreotide scans, and you can see that the octreotide scan, yeah, we see some tumors, but there's a little fuzzy. And now with the dot-to-day or either copper or cystic gallium, we can see that how the tumors are very well delineated, very well seen. And that's the reason why with the developing and approval of this imaging has definitely evolved in how we follow and manage patients with neuroendocrine tumors. And that's where Dr. Shahan will discuss more about theranostics. So what theranostic means is the combination terms of therapeutics and diagnostics. So you have a skin, that's your diagnostic, which is either a 68 gallium or the 64 copper dot-to-day skin, and then you have a target. So I have to say, I like to see this, I like the lock and key kind of like thought, where you have here the lock here, so you have the tumor cell, and somatostatin receptor is the lock, and then you have a ligand, which is the key. And that's why when you kind of like put the key into the lock, then when you do that, there is going to be a series of effects, and that's how we treat these tumors. So this is a type of radiation therapy, and that's the reason why if we have a patient that has a positive dot-to-day scan, patients are eligible for PRRT, as we discussed, peptide receptor radionuclear therapy, which is a type of radiation, and with Lutathera. And we discuss more about that because now there is a PRRT with alpha, and Dr. Shahan will discuss more about that. So this is the studies where the dot-to-day was approved. Initially, that was from the Netherlands, but that's where based on this data, the investigators who run the study, they saw that there was a benefit of giving Lutathera because they saw that they stabilized the tumor for long periods of time. The only thing about this treatment is like very few patients saw that the tumors shrink. And because of that, even though it's an excellent treatment and we recommend it usually as a second-line therapy, because of that, one of the research that is ongoing, could we make Lutathera more effective? We know it works, but could we make it more effective to be able to shrink the tumors even more or in more patients? And that's what Dr. Shahan will discuss later about. There's now combination therapies with Lutathera, and just wait for his talk, which I'm sure is going to be fantastic. I know that I only have a few more minutes. And this is how it's given. So the doses of Lutathera is 4 doses that is given every 2 months. In order to be eligible for Lutathera, you need to have a positive dot-to-day scan, and that's how it's given. It's only 1 dose. Sometimes in patients that have kidney dysfunction and we think that may benefit, we may decrease the dose of Lutathera, of 177 lutetium dot-to-day. Now, I'm just going to mention this, and I'm sorry about these busy slides. I just wanted to focus more about what is this combination chemotherapy. This is 2 pills. They're combination chemotherapy, temozolomide and capecitabine. We call them CAP-10. They are both chemo pills, and basically what they do is that they're able to shrink the tumors, but we see it more on the pancreas neuroendocrine tumors. We don't necessarily see the same effect on the small bowel neuroendocrine tumors, and I think that's important to recognize and also to discuss with our providers as well. And initially when the studies were done, they also were able to shrink the tumors more than other therapies for neuroendocrine tumors. So if I see a patient that have a pancreas neuroendocrine tumors that is causing symptoms, or we see that there is many tumors in different part of the body, if I wanted to shrink the tumors, I would recommend to give CAP-10 as a first line of therapy. So these are the different options. So we discussed a lot of the systemic therapy. Dr. Blakely and Dr. Malucci will discuss about the indications of when to do surgery. We discussed about when to use somatostatin agonists, either of lanreotide or octreotide. Dr. Cassin will discuss later today about the different type of liver-directed therapies, either with ablation or embolization. We discussed about the CAP-10, which is recommended for the pancreas neuroendocrine tumors, and we discuss about everolimus. And this is my sequence of treatment. So, and that's something maybe somebody else may recommend something different. If I have a patient that have a small bowel neuroendocrine tumors, I may start with somatostatin agonist first, depending if there is a large, many tumors in the body versus low tumors in the bodies. Maybe I want to observe if I see that the patient doesn't have any symptoms and there is low tumors, maybe I want to observe for a little bit. But if I feel that there is symptoms and I wanted to give something systemic, then I start with the injection, small injection, either with lanreotide or octreotide. If I see that the tumor growth, then for a small bowel, then we can consider PRT with Lutathera or everolimus as the next option. If tumors grow with these therapies, so then we need to discuss about what are the therapies, and that could be either this, we discussed the tyrosine kinase that blocks the blood vessel supply going into the tumors, or clinical trials. And I think now with the alpha PRT on the, of the Lutathera retreatment that Dr. Shahan will discuss later today, those are possible options as well. We think that if the patients have benefit of getting Lutathera here, it's possible that the retreatment will be another option. Dr. Shahan is actually opening the study for that, so I wait for this afternoon to discuss about that. There are certain chemotherapies that can be prescribed in certain situations. That's something that we need to discuss with the medical oncologists, because there are specific chemotherapy agents that we could consider, but it's not something that we necessarily discuss in the first few lines. Now, if a patient have a pancreas neuroendocrine tumors, if I want the tumors to shrink because the symptoms, maybe I want to consider the chemo pills as we discussed. If it's overall stable, if it's functional, maybe we can discuss about adding some somatostatin agonists, usually as a first line, or if I wanted to also help with the symptoms related to hormone excess and shrink the tumors, maybe I can give the combination. So it's kind of like, that's the reason why it's very important to understand, patient by patient, to then provide the best options and more personalized. And that's why I discussed earlier that the treatment of neuroendocrine tumors needs to be discussed with a multidisciplinary team to then tailor what would be the best treatment algorithm. And as we can see here, if there is a tumor's growth on this, there are different treatments like PRT with Lutathera. We have the everolimus, as we discussed sunitinib, we discussed the chemo pills. And again, these are the different options that we have. So with that, I'd like to conclude. I think that's, and then very briefly, we do have clinical trials available at the NIH. We have natural history study to allow us to follow the patients long-term for neuroendocrine tumors, as well as other neuroendocrine tumors, more rare, called pheochromocytomas or paragangliomas. We do have treatment studies for the gastric and pancreas neuroendocrine tumors with Lutathera in combination with a pill called olaparib, because as I discussed earlier, what we're trying to do is, like, we know the Lutathera works, but can we make it better? Can we make it more effective? Can we make it to shrink the tumors even more? And that's what we're trying to answer. We're doing this study to answer that question. And we have other studies for pheochromocytomas and paragangliomas. And again, I do believe that for the management, pediatrics and adults, that we need to have a multidisciplinary team. We're fortunate at the NIH that we have good experts, including Dr. Blakely here, who's going to speak after me about the management of these neuroendocrine tumors. And this is my conclusions. I think I ran out of time, but we know that we need to understand the patient's status or how they present with neuroendocrine tumors based on the site, based on the grade, based on the whether it's producing hormones or not, whether the tumor is expressing the receptors or not. Some of these tumors may produce hormones, and then we need to address those as well. We have now quite a few tools for the management of neuroendocrine tumors, but we also need to discuss with our patients what is the best treatment algorithm, and that's very personalized on patient to patient. And again, I think treatment for every patient requires a careful balance of patients as well as treatment characteristics. And with that, I would like to thank you all for your attention. I think this is the last one, and to NCAN as well.